I'm Gina Del Savio. I am an orthopedic hand surgeon here at Montefiore St. Luke's, Cornwall. So in any case, I've been up here in the community since about 1996, a part of orthopedics and sports medicine for many, many years. I came here out of Columbia Presbyterian, where I did a hand and microsurgery fellowship after doing my orthopedic residency through New York Medical College. So at this point in my career, the only thing I do is hand surgery. So I operate from the elbow down. And although I am also an administrator here, I still do see patients in the office and I still do surgery and I still cover our emergency departments, as you just saw. So anybody starting to talk off about carpal tunnel. First thing I want to make clear is that everybody has a carpal tunnel, just not everybody has carpal tunnel syndrome. Carpal tunnel syndrome is an abnormality with the carpal tunnel. And it tends to happen in folks who are manual laborers or hairdressers, cake decorators, truck drivers, people who do a lot of handiwork, crafters, knitters, and motorcycle riders as well. So what is the carpal tunnel? This is the thing that everybody has. In everybody, and again, if you can see me, the nerve starts by coming off at your level of your neck, and then it actually goes down your arm. And when it gets to about here on your wrist, as you can see the picture, the nerve has to somehow get to the tips of your fingers. And it does so by going underneath the wad of muscles in that transverse carpal tunnel ligament. And the problem is that on the other side of your wrist, there's bones. So literally the nerve is traveling between a rock and a hard place. And that's where the nerve can get pinched in your carpal tunnel. So again, everybody has a carpal tunnel, but carpal tunnel syndrome is a nerve problem when there's pressure on that median nerve right there where we were showing you in the palm of your hand. So again, if you take a look at this, Halloween prop, it's good news we're getting into October. You can see the person's thumb, you can see their pinky. And if you look at right here, here's the bones we were talking about on the back of your wrist. Here's the muscles on the top of your wrist, and traveling in between in this carpal tunnel space is a bunch of tendons, as well as right there, that's your median nerve. And what does the median nerve do? It gives you sensation to your thumb, your index, your long finger, and for most people, even the one side of your ring finger. So if you've got carpal tunnel syndrome, you may say, oh, it's so weird. Why is one side of my ring finger feels normal, but the other side of my ring finger feels tingly? That's because that's what the median nerve does. It gives sensation to those particular areas. So what is a nerve, right? So we just talked about the fact that there's this thing that comes down off of your spinal cord and goes down to your fingers and travels in that tight space. But what is a nerve? Think about a nerve as like an electrical cable, all right? And just like you have an AV cable, it has audio, visual, it has two different kinds of things traveling through it. Most nerves have two kinds of fibers running through them, sensory fibers and motor fibers, all right? So it's a biological electrical cord, which is carrying messages to and from the brain via the spinal cord, and it goes in. So the median nerve actually, again, starts at the level of your brain with some fibers which are going to be carrying motor signals down to your hand so that when you say, make a fist, you do that, right? Versus other things, I touch the hot stove and it comes up and it goes, oh, move your arm out of the way, that was really, really hot, right? So it's a bidirectional electrical cable attaching the periphery, your hand, to your brain. That's what a nerve does. And I just have to stop clicking twice and then we'll be just fine. All right, so what are the symptoms in carpal tunnel? Well, as I said, the fibers are two kinds. There's sensory fibers and there's motor fibers. And as we talked about, the sensory fibers go to your thumb, your index, your long, and partially to your ring finger. And so you can either have numbness sometimes, you have numbness which is constant, and maybe you don't feel like it's really a numbness. Maybe it's more of a burny feeling, or maybe it's that when you touch things, it's uncomfortable, like almost like chalk on a chalkboard. When you go to feel things, you don't like things rubbing against your fingers. Some people even talk about a really painful pressure underneath their fingernails. But what it is, it's an uncomfortable feeling, and the distribution is going to be to those four fingers. And then, of course, there are the motor fibers that we talked about. Now, which muscle is fired up by the carpal tunnel nerve? Well, what's fired up is the muscles at the base of your thumb, so you can have some weakness. Now, usually with carpal tunnel, because of all those structures you saw in that carpal tunnel that we were showing before, It'll hurt when you do repetitive finger motion, right? Those tendons rubbing against your nerve. Grabbing a power tool or a blow dryer, anything that vibrates and is a little heavy as you're squeezing it, that can aggravate it. That goes along with driving as well, especially if you have a car where it's a bigger steering wheel or it's a heavier vehicle and you have to grip the steering wheel super duper tight, or you're riding on bumpy roads. Driving can aggravate it. Weight bearing. I ride my bicycle, either whether it's an exercise bicycle or whether it's a dirt bike, and I'm leaning my body weight forward on my handles. That's going to, again, accentuate the pressure across that carpal tunnel, and that's going to give me those symptoms as well. And again, prolonged putting your wrist into weird positions, like holding your wrist all the way back, holding your wrist all the way forward for long periods of time, can also give you carpal tunnel. And a weird one that not everybody can make sense of is in bed lying down. And it's kind of funny because that's the number one complaint that people have. Because quite frankly, if you're driving and your hand goes numb, you drop it and you shake it. And it's probably not enough for you to call my office and make an appointment and pay a copay and sit around for an hour to wait for me to see me, because you can do this and you can make it go away. The reason that people end up in my office is because it gets to the point where they climb into bed at night, and when they're lying flat, now the hand goes numb. They try putting it on a pillow, maybe they even read the internet and they put a brace on or doing stuff. They sleep with their hands between their legs. People have told me that. But when they're in bed lying down, so now this is disturbing your sleep, that's the numbness that drives them crazy and gets them into my office. And as I said, some people through experimentation figure out that if you keep your wrist straight, whether it's between your knees, whether it's because you sleep like this, whether you lie like this, or because you put a brace on, it makes the numbness less because you're not crimping that nerve and you're not stretching that nerve. Other people discover, oh, all right, lying flat is what kills me. But if I do this, or if I dangle my arm over the edge of the bed like this, that makes it feel better. So again, I'll say to people, what can you do to make it better? Oh, I dangle my arm over the bed, and if I shake it, it feels better. And then, of course, you can always make it feel better by just simply not doing the things that aggravate it, like driving the car, using the blow dryer, but you can't avoid sleep. So that's why when it gets to the sleeping activity, that's usually when folks show up in my office. So how do I make the diagnosis, right? What tools do I have? Well, the best probably tool I have is listening, right? Because oftentimes the carpal tunnel is me really listening to you, who is the patient, because you may not have numbness when you're sitting in front of me, but you're going to tell me about your numbness. You're going to tell me the time of the day that your hand bothers. You're going to tell me what activities provoke the hand and make it feel worse. You're going to tell me about your history of your activities, your hobbies, your job, maybe previous injuries that you broke your wrist or cut your wrist. You're going to tell me about what can you do to make it feel better. You've tried a brace, you tried anti-inflammatories, you've tried sleeping with your hands in weird positions. So again, 9 times out of 10, I know you have carpal tunnel probably before I even touch you, if I'm really listening to what you say and I really ask you the right follow-up question. So history is really, really, really important. Physical exam. So I'm going to look at you, I'm going to touch you, and I'm going to do some provocative tests, which we're going to talk about in just a second. And then, of course, we do have some objective tests that actually measure the nerve, and those are called nerve conduction studies and electromyograms, also known as NCSs and EMGs. And some of you may get a prescription from your doctor that says, oh, before you see the hand surgeon, I'll have to get an NCS EMG. Well, what is that? That's where a physiatrist or a neurologist or a technician plays electrician on your arm. And what they basically do is they will put an electrode down your arm, and just like an electrician will test a wire from here to here. Is it conducting okay? Oh, that's not where the problem is. Is it conducting okay from here to here? Oh, it is. Well, that's not where the problem is. Is it conducting okay from here to here? No. Aha. Now we know the problem is here. That's what a nerve conduction study looks at. It looks at where does the nerve not conduct signal well. An electromyogram is little tiny like acupuncture needles, which we don't use in everybody, but sometimes when we have a tough case, we're trying to figure things out. And they put that little tiny needle into your muscle, and then they see whether or not your muscle is getting signal from the nerve. So if we test the nerve itself, and then we test the plug where the nerve plugs into your muscle by looking at those electromyograms. And that's the one and only objective test that we actually have for carpal tunnel. There's really no roles for x-rays, ultrasound, CAT scans, MRIs. they don't show us diddly squat unless I can't make head or tails and I start looking for weird things like, do you have a fatty tumor in your carpal tunnel? That's what's pushing on your nerve. That might be the only time. But other than that, for straightforward carpal tunnel, which is really provoked by activities, there's really no imaging that's necessary. So we've talked about physical examination. So when I use my eyes and I'm looking at you, what do I look at? Well, I'm going to look at the muscles that are at the bottom of your thumb. So here's somebody's hand, right hand, with a beautiful big wad of muscles at the bottom of their thumbs. And if you come over here, you'll see that that wad of muscles doesn't look quite as full, right? It's not a ball of muscle, it's flat. Why does that happen? Well, because one of the things that carpal tunnel does when it comes to your wrist, comes to your wrist, comes to your wrist, not only does it send fibers for sensation out to your fingers, but it also has a little branch that goes and plugs itself right into that muscle. And if the nerve is being pinched, then that branch that plugs into that muscle isn't plugging into the muscle. And if the muscle's not constantly being stimulated by the nerve, the muscle begins to waste away or atrophy at the bottom of your thumb. And so for people who have long-standing carpal tunnel, you will actually see a flattening or a wasting of that muscle, which is going to translate into the bottom item, which is now you're going to have some weakness when you try to pinch things, okay? And then we've talked about the touch being either decreased sensation or hypersensitivity. So that's what I can do by examining you. And then, of course, there's provocative tests. And what that means is I try to recreate your symptoms. If I do these things and you tell me, well, that feels weird or that hurts, but it doesn't recreate my numbness, the test is not positive, right? These are tests where I try to provoke your nerve and then I get you to articulate to me, did I just mimic those symptoms that wake you up in the middle of the night or the symptoms that bother you when you drive your car for a long period of time? And if I do, that's when we consider the test positive, because now I know that provoking your nerve recreates your symptoms, then the nerve is where the problem is. So one of those tests is called a Tinel sign. And a Tinel sign is simply tapping your nerve, all right? And if I tap your nerve and you go, whoa, electric shock out into my fingers, that's exactly the sensation I feel at nighttime. Oh, okay. So your nerve is angry, because my nerve right now, sitting here right now, I don't have carpal tunnel. It doesn't bother me in the slightest. I tap this all day long. I don't feel an electrical zoom. The time that you get an electrical little zoom is when the nerve is angry and a little bit irritated. It's like having a bruise. It doesn't hurt me if I do this, but if I have a big old bruise because, my husband slammed my arm in the door yesterday, when I do this, it's going to hurt. So the same thing with tapping on that nerve. If that nerve is aggravated or irritated or under pressure, tapping on it will solicit this abnormal pain and electrical shock into your fingers. The second test that we like to use is something called a Phelan's maneuver. And this picture here shows somebody doing this, but honestly, you can also do it with just like a little puppy dog like this, or you can do it like this. The bottom line is that you're putting your patient's wrist into a really, really exaggerated position. And why does that recreate your symptoms? Well, think about what the picture that we saw, right? If you think about that picture that we saw, that nerve is traveling through that tunnel. And that tunnel is as big as it's ever going to be when I hold my wrist like this. As soon as I do this, I'm squishing my nerve. As soon as I do that, I'm stretching that tight band and pushing down on my nerve. By the way, that's why a brace feels good. It keeps you from crimping your nerve or stretching your nerve, especially while you're sleeping. It keeps you in this neutral posture, which is why it makes you feel better. But it's also why if I push your wrist down and I make you hold it there, or you just put you down and hold it there for a period of time, or like this, if that pisses off or recreates your symptoms, that's another sign for me that you have a nerve which is angry and not happy. So what do we do for carpal tunnel? Well, I think I've said it repeatedly here. Carpal tunnel is actually a mechanical problem. So it's a mechanical solution. This is not a pill. This is not a rub. This is not physical therapy, okay? This is try to maximize the space in that tunnel with bracing or avoidance of aggravating positions and postures and activities. And if that does the trick, awesome, you can manage your carpal tunnel. But unfortunately, if you cannot avoid doing the activities like sleeping, right? The brace doesn't help you when you sleep anymore. You still get numbness and tingling, or you drive a truck for a living. You cannot stop driving, or you are a dental hygienist and you can't stop scraping plaque off of people's teeth. That's what you do for a living. That's how you pay your rent and put the food on your table. Well, guess what? Now we have to get a little more aggressive, and I have to go in there and actually make the space bigger. Instead of trying to manage the tight space that you have, I, as the surgeon, as the mechanic, can surgically open up that space and make it bigger. This is what the typical wrist brace looks like that you sleep in. Please notice this is not that usual black streamlined verse that you see when you sprain your wrist. This has a lot of padding on it. And the reason for that is you're sleeping in this. I don't expect you to wear a carpal tunnel brace when you're going about your day, because quite frankly, you're going to give yourself some form of tendinitis. You take your wrist out of the mix and you try to do everything with your fingers, you're going to end up with other problems that I've lectured on, like trigger fingers or de Quervain's tendinitis, or you're going to get calluses across your hand, or you're going to give yourself tennis elbow because you're doing everything through your elbow because you took your wrist out of the mix. So wrist braces should be used at night. I tell my patients, you put it on your nightstand, you put it on when you climb into bed, you take it off when you get up in the morning, and if you find yourself needing to use it during the day, it's time to visit your friendly hand surgeon, all right? That means that the brace is not doing the trick anymore. But again, just notice that this is a really well-padded brace because you're sleeping with this, and it should be comfy as you're trying to sleep with this brace on your hand, not this rigid, sharp thing with sharp edges that rub into the palm of your hand. A little bit about carpal tunnel cortisone injections. I am not a fan. There are people who will do these, but here's the challenge with cortisone injections into the carpal tunnel. One, you're putting a needle into a space that's extraordinarily tight, and your nerve is just under the rim of this ligament. So what you can do is go to the right side of the nerve and put the needle in there and flood it with cortisone. But now what you're doing is it's like taking a water balloon and putting more water in it. It's already tight, for crike's sake. That's why you're in my office telling me you're not. So I'm going to put more stuff in a sausage that's already overstuffed. That just doesn't work for me. All right. And I'm not alone. There are two schools of thought around carpal tunnel cortisone injections, those people who don't like them and those who do. And the thing that holds out for those of us who don't like cortisone is that everybody will agree, everybody, whether you like cortisone or not, cortisone doesn't cure carpal tunnel. It doesn't. Everybody agrees on that. It is a temporary measure, which for some people can diminish their symptoms, but it doesn't cure it. And so for those of us who don't believe in cortisone injections, we're like, why are you going to stick a needle in a place where you can cause damage when you know you're definitely not going to fix the problem? We would recommend, if you've got to the point where you feel bad enough to need a cortisone injection, it's bad enough to do surgery, which is a definitive treatment and will make you better. All right. So what is carpal tunnel surgery? Well, we talked before about your nerve traveling underneath this tight band of tissue between a rock and a hard place. Well, I can't do anything about your bones, but I can release that ligament that goes across the palm of your hand. Now, there's two ways that we can release that ligament. One is a traditional open procedure, and another is called an endoscopic procedure. All right. And we're going to just I'll show you some pictures of both of these, but there's two ways to fix it. The challenge is that even though the endoscopic procedure has now been out for close to 2 decades, we know from long-term studies that the open carpal tunnel release has not only a better outcome in the short term, better outcome in the long term, there's less recurrence and there's fewer complications when you do it open. So honestly, although endoscopic is a very sexy operation and the sell for it is that it's a smaller incision, skin incision, the reality of it is if you go out 6 weeks, the two people, whether you had it open or endoscopically, you're at the exact same place. And if you go out 10 years, if you had it open, you're less likely to have had a recurrence and you're less likely to have had a complication. So again, 2 ways of doing it. Again, we talked about the anatomy. There's that tight ligament pushing down on the nerve, and you can see that ligament being released. And again, that can be done through the skin or endoscopically. This is what an open carpal tunnel release looks like. And this is a very old picture because I will tell you that nowadays our incisions only go from about here to about here. What we've learned is that this last part of the incision is most of the time unnecessary unless people have had a previous injury or have some scar tissue, or very occasionally in morbidly obese people. And we just can't see because when you get heavy enough, unfortunately, there's also fat in the hand. And we're doing a nerve release. You obviously want to see what the heck you're doing. When we do these releases, we do lift right here, and the release actually is already also done back to about right here. So when we finish with you, again, the release is going to be probably from about here to here, but it's done through an incision that goes from about here to about right here. All right. Now, this is in contrast to an endoscopic carpal tunnel release, where you can see that an incision is made across the wrist. And this is, by the way, not much smaller than the incision that I would make down your wrist. And then through that hole, you slide an instrument all the way to the end of the carpal tunnel, and then you pull a blade back to cut it. Now, one of the reasons why that this can have a complication is because I don't know whether you can see here, but there's another nerve right here called the ulnar nerve, which, you got to make sure that this blade, because you're doing it somewhat blindly, you're making a guess that this person doesn't have some weird anatomy, and this is super duper close to where your blade is. Also, if you recall, we talked about a branch that plugs into the muscle. Well, that motor branch, most of the time, comes under the carpal tunnel ligament, comes out up this side, and plugs into the muscle. That's what it usually does. But that's only in about 30% of people. In about 70% of people, that branch comes on top of the carpal tunnel right here, or pierces the carpal tunnel ligament here, and then goes into the muscle. So for those folks, again, if you're doing this type of procedure, you run the risk of damaging or lacerating that nerve and therefore losing the strength. Maybe you get your sensation back because you've released your ligament and then the pressure on the nerves that gives you sensation to your fingers, but unfortunately, you do run the risk of then damaging the nerve that actually gives you power to your thumb. Either way we do it, this is an operation where you come in and go home the same day. It's done as an outpatient procedure. It is done in an operating room, and that is for sterility purposes. Nobody wants to get an infection. The risk of infection in this particular procedure is well under 1%, as long as it's done, obviously, in a sterile environment. The anesthesia that we use, well, we do put an IV in the hand that we're not operating on. That's where you get some antibiotics to minimize your risk of an infection. But it's also so that we can give you some twilight anesthesia. Nobody really wants to remember their carpal tunnel release, and so we give you a whiff. And I do really mean it. It's a whiff that makes people sort of snooze. No tube in your mouth or anything like that. The anesthesiologist is obviously there making sure that you're breathing okay and giving you some extra oxygen. But just so that you're out of it enough that I can stick a needle in your carpal tunnel and numb it up with a local anesthetic. And then usually 5 or 7 minutes into this 12 to 15 minute case, the patient's going, oh, where am I? Have we started yet? And I say, oh, we're almost done. So again, it's a local anesthetic with a twilight anesthesia. When you leave the operating room that day, you have an ACE bandage, no cast, no splint, and as I like to say, no pain, because you've got Novocaine in there, right? We did a local anesthetic, and we use a local anesthetic that actually lasts 24 hours. And because this is a soft tissue procedure, you're moving your fingers and you're moving your wrist the day of surgery. As I tell my patients, you're going to feed yourself, wipe yourself, dress yourself today. And then once the drugs are out of your system that the anesthesiologist gave you, we let you drive your car 24 to 48 hours later. The restrictions are, of course, is that you do have 5 or 7 stitches in the palm of your hand where I opened you up. I do the open approach. I did the open approach to, let me just get somebody in here. To do the release. And of course, those stitches have to heal. So for the first 2 weeks, we ask that you keep the dressing clean and dry. All right. No putting bacitracin or Neosporin on, no jumping in the swimming pool, no going to the gym and getting your sweaty paws on an elliptical, right? No. Keep that wound clean and dry. And for lifting precautions, because I did release that ligament inside your wrist, for the first 2 weeks, try to lift things less than a quart of milk. Because again, you could feed yourself, wipe yourself, button your buttons, snap, zip your zippers, but I don't want you lifting anything heavier than a quart of milk. At week 2, you come to the office, we take off that dressing, we clean everything up, we get out your stitches, and ta-da, because the stitches are out and your wound is healed, now you can get it wet, sweaty, disgusting, and dirty again, right? Let you start putting some lotion, some vitamin E and cocoa butter in there, jump in a swimming pool if you want to. And now what I say is, okay, I know you're healed enough to start lifting, and everybody heals a little bit differently between weeks 2 and 4. So I let you lift within tolerances, meaning that if you can lift a gallon of milk and it doesn't hurt, lift a gallon of milk. But if you feel a twinge when you lift it, use the other hand. Give your body a little bit more time to heal. That's your body's way of saying you need a little more time. Once you get to week 4, however, it's healed. It's healed. At 4 weeks, you are released to full activity. So even if it does hurt a little bit to lift that gallon of milk in a month, it's okay. You're not going to damage it if you push through discomfort at that point in activity. All right. So what I tell all my patients is that for 4 weeks, I'm going to put some limitations on you. And between week 4 and week 12, you're going to find that you limit yourself a little bit because you're not going to quite feel up to it. You are going to feel twinges when you do things, but you're not damaging anything. So I'll let you do everything at 4 weeks, but you'll probably limit yourself up to about 12 weeks when most people are back to doing everything and not having any issues in terms of pain or disability. All right. Those of you who have been with me before, actually, I do have some orthopedic tidbits that I do like to run through with everybody. A little less about carpal tunnel, maybe give you a chance to think of any questions you might have. Just a little bit of basic education for folks. NSAID, you hear people talk about NSAIDs. NSAIDs, it stands for non-steroidal anti-inflammatory drugs. And there's a lot of them out there, and it gets confusing because people are like, well, I can take ibuprofen, but I can't take Advil. They're the same. Okay, so Advil, Motrin, ibuprofen are all the same medication. Advil is the over-the-counter version, so it's 200 milligrams per tablet. Ibuprofen, you can buy it in 200 milligram tablets, but what a waste when you can buy Advil, right? Especially the generic Advil. Ibuprofen is usually when we're talking about the prescription generic medication, and there you're talking about 400, 600, 800 milligram tablets. You can take up to 800 milligrams of ibuprofen at one time, and you can take up to 2,400 milligrams in a 24-hour period. So you can get a prescription from me for a couple of 800 milligrams and take 3 a day, 8 hours apart, or you can take 2 Advil every 12 hours, all right? So again, but it's the same medication, Advil, Motrin, ibuprofen. Same thing with Aleve, naproxen, and naproxen. Aleve is the over-the-counter version, and all that means is that it's a lower dose. If you take enough Aleve, you've now taken the prescription strength of naproxen. Tylenol, as we all know, is not a prescription medication, and its generic name is acetaminophen. And one thing to keep in mind is that Advil and Aleve are anti-inflammatories. Tylenol is not. Why is that important? It means that I don't want you to take 2 Advil, and if you're a little uncomfortable a little bit later, go, let me try some Aleve. No. They're both metabolized the same way. They both go to your liver. They both bother your stomach. You don't mix non-steroidals. You just take one and stick to it. Once it's out of your system, if you feel that it didn't work, 8 hours later, you want to switch to a different one, you can do that, but you wouldn't take them at the same time. Tylenol, on the other hand, is a different family of drugs. It is not a non-steroidal. So if you take my 800 milligrams of Motrin and you're like, well, I'm still a little achy, take some Tylenol. In fact, next time around, take 2 Tylenol, take an ibuprofen, all in the same mouthful. They don't interact with each other. They can be taken together. Orthopedic tidbits further, occupational therapy versus physical therapy. Sometimes people say, well, do I have to do therapy after I have a carpal tunnel release? 50-50. If you need it, you do it. If you don't, you don't. And the difference between occupational therapy and physical therapy is how a therapist is trained. Occupational therapists spend an inordinate amount of time on the upper extremity. Why? Because part of what an occupational therapist does is gets people back to activities of daily living. And most of what we do for activities of daily living, it's buttoning buns, opening jars, peeling a potato, opening up a can, tying your shoelaces. And that all has to do with your hand. And so occupational therapists are very, very familiar with the anatomy of the upper extremity because our arms are used for all of those things. And so I, as a hand surgeon, will often refer a post-operative patient who's had hand or wrist surgery to an occupational therapist because it's their thing. Like I'm a hand surgeon, that's all I do. They're hand therapists, that's all they do. Versus physical therapy, physical therapists train on the whole body. One patient, they could be treating, 3 patients at a time. One's got neck problems, one just had a total knee replacement, and the other had a carpal tunnel. They do the whole kit and caboodle. And that doesn't mean they can't do it well. It just is a different training. It's a different focus. So for instance, if you have tennis elbow, I actually feel very comfortable with you going to either therapist because they're both probably trained equally. If I did a tendon reconstruction on you, which is a really complex procedure, I really need you to go to an occupational therapist because they know the anatomy much, much better than a physical therapist, and they're going to do better for both of us and get you back to doing what you need to do faster. So different training, different therapists. And if you ever have a question about who you should go to for any particular problem that you have, just check with your orthopedic surgeon and they'll be happy to give you some guidance. Because as I said, sometimes you can get away with doing PT. And by the way, there are some PTs who do a hand fellowship, meaning that they're a physical therapist but they've actually done extra training in the hand. A local version of that is Dan Fishman over at Peak Physical Therapy. He's a physical therapist, but he actually did some extra training in the hand. So I've used him as a physical therapist to take care of my hand patients, no matter how tough the problem is. And then, of course, at Access for Living, they have Emily Boccacelli, who all she does is OT. So again, there's lots of ways to skin the cat. So just check with your doctor. If you have a therapist that you want to use, usually we can give you guidance based on what your problem is and the training of the therapist that you think that you'd like to use. And then one last tidbit around opioids. We all know we're in the middle of an opioid crisis. Life is terrible here. And I'm going to be transparent in that when I came out in practice, I used to give people 20 Vicodin after a carpal tunnel release. I'm embarrassed, but I'm saying it because you have to understand how the world has changed. Now, when I open up somebody's wrist fracture and put plates and screws on both sides and bone graft them in a 2.5-hour operation under general anesthesia, I give them ibuprofen and Tylenol. The world is a different place. We've learned that Motrin, Advil, ibuprofen with Tylenol is as good as Vicodin, Norco, and Percocet, and they're not addictive. So 2 take-homes is that if your orthopedic surgeon says you don't need opioids, believe them. We don't. Even our total joints now go home with ibuprofen. And if for whatever reason you are given a narcotic, because it's determined that that's absolutely necessary, please, please, please be mindful that these drugs all have Tylenol in them already. So if you've taken that Norco or the two Norco or 2 Vicodin or 2 Percocet that your doctor gave you and you're still uncomfortable, don't go reaching for the Tylenol or the acetaminophen bottle. You can actually overdose on Tylenol and put yourself in liver failure. So be very careful with that. Ironically, here, you actually can use an Advil or Motrin with these drugs, because if you'll notice, they don't have those things in there. So again, it's always be important to know when you're taking these kinds of drugs, what's actually in that pill. So if you do need to take something else in addition to it, understanding what the underlying issues are. And again, you can get that advice from your physician or by looking that stuff up online. Last but not least, what's an allergy versus a sensitivity? When a doctor says what you're allergic to, an allergy is when your tongue swells, all right? A sensitivity is if you get nauseous, you feel a little spacey, you get a rash or hives. And it's really, really, really important for you to tell your doctor which of these reactions you have, because oftentimes when you say you have an allergy to one drug, you just eliminated a whole slew of medications we could use to make you feel better. And if it really was just a sensitivity, we still have a long pick list. So try not to limit the tools we have to help you by really narrowing down what's an allergic reaction versus a sensitivity. And medication, if you're on medication, write it down, bring it everywhere you go. So, because oftentimes when you don't feel well, that's the last time you want to try and have to remember your medications and your dosages. Narcotics we've talked about. Thank you.